With this said, let's move on to a very important component, of course, that all of us are involved in as oncologists, which is systemic therapy. And I'll start with Martin, I'll just put it like right off the hat here. What do you treat patients with cholangiocarcinoma with systemically?
So actually, the first line, cisplatin gemcitabine is kind of the regimen for me to go. In that case, based on the ABC02 data, with improvement in survival at that point. So that is my first line. I echo Andrew's point. When you have an R2 resection, I will treat them the same way as the systemic therapy comes and start chemotherapy for them.
Fair enough. So you even carry it with the R2, which I totally understand. Andrea, one question that we might sometimes face from different doctors is GemOx versus GemCis.
Yeah, so that's a good question. I generally go by the book and use the GemCis. And I think a GemOx has been used quite often. And if we treat patients sometimes with GemOx, we do see good response. But however, I think there are multiple studies have shown, it is the GemCis was proved to be sort of a level 1 evidence by multiple, by the ABC002. So I still use the GemCis. However, if patients have a kidney problem, and sometimes I do use GemOx, yeah.
Fair enough, and definitely there's a little bit of a drive sometimes regard to oxaliplatin, but I totally agree with Andrea that the GemCis, because where the data came from, was a survival improvement, kind of like touching onto close to between 10 and 11 months in regard to the GemCis will make a lot of sense. Now, Andrew, one of the challenges that we have with the ABC02 is that something that we noted is that the PFS is rather very close to the survival. The kind of like there was not much of a difference per se. Your thoughts on that?
Yeah, so if you look at the PFS, for the ABC002, it was actually 7 months, and the median survival, was 11 months. So I think clearly the benefits was driven by the first-line regimen because I think we really do not have any second-line treatment at that point. So I think the benefit that it derived clearly was mainly because of the first-line regimen. But having said that, the field has been staggering, for quite a while since the ABC02 trial. And we actually do not know what additional treatment is better than GemCis alone, but also, what could actually offer the patient if they progress on GemCis, yeah.
Teresa, your thoughts on ABC02? Let's begin with that.
Yeah, I think, of course, in that moment, we didn't have any second-line treatment options or approved. So probably a lot of patients are only treated in first line with no other options.
Yeah.
I think it's a positive trial. And for me, it's my standard. If we have the standard with cisplatin and gemcitabine, I prefer to treat with this combination that with gemcitabine and oxaliplatin, but that we don't have the phase 3 trial, the randomized phase 3.
Along that line, a question for you, and probably you are the right person to ask because you practice here in Europe. The ABC02 required or limited the treatment to 6 months. While in the US, we kind of carry on with treatment until progression or intolerance. Your thought on that, or how do you practice, or how do you read the data?
Yeah, I don't like to stop the treatment.
You don't? Okay.
No, and I try to stop the cisplatin after 6 months normally due to the toxicity, but I continue with gemcitabine as maintenance monotherapy. But there's a lot of physicians here in Europe that stop after 6 months. It's very common. It's very common.
Sure. Quite fascinating. If anything, we're hearing about GemCis, which is very fine data that was built on the ABC01 that the data off was moved to ABC02, and ultimately we had an improvement in survival, which about 11 months versus 8 for the GemCis versus Gem. And we give a lot of credit for the UK group in regard to that data. That really became standard of care, as we heard from all of us on all our hands. 2 challenges that come with that study is, number one, understandably, the progression-free survival was rather kind of high, and we all know that progression-free survival is dependent on a very important variable when you look at it. And in others, if you do a CAT scan every week, you'll be able to get a progression-free survival that's really more kind of specific and maybe will be determined by when you do those scans. But on the other hand, if you do the scans less often, you only can register that progression-free survival whenever it happens. on the ABC02, the frequency of scans was less than we do in the US, and that's why probably the progression-free survival was more than what quote-unquote could have been expected to. This is something that can be revisited. Why we bring this information? Because of course we need the references for those studies, and how can we depend on them for whatever future studies we're going to do per se. The other point that was brought up is exactly as Dr. Makaria brought up, which is like, do we stop after 6 months? There's a certain approach in the UK that after 6 months of therapy, that's it. We can stop the treatment, because they're trying to measure it from different perspective, being, of course, benefiting the disease and make sure it responds. Number two, preventing any adverse events. And number two, of course, the functionality of the patient per se. In the US, and as we just heard, even for certain physicians and colleagues of ours in Europe, there's probably a carry on in the therapy until progression, or until there is a adverse event that might limit per se. And for that reason, yes, as we heard from Dr. Makaria again, is that there could be some practicality where we might stop the cis first, continue with the gem. And by the way, there is a theory that maybe a certain remembrance effect for the cisplatin can carry on after the cisplatin was discontinued while the gemcitabine is on. So by all means, there could be variation on how we're applying it per se.